Good afternoon. I'm really thankful from the bottom of my heart to Sir Dr. Raju sir and dear Madhu to have me on this podium. So the hypermature cataracts, deal them with poise. Basically, it is the advanced stage of the cataract, which is dense and rigid and opaque, and if left untreated, difficult to deal with so many unique surgical challenges. Thing is that it has got a sometimes got liquefied cortex, the nucleus is mobile, or the risk of the facultative glaucoma or general weakness. These are four things. That is, you have to deal with sometimes Argentinian flag sign. There can be rupture in the PC, and if the time is more, the corneal decompensation, or still there can be dropped nucleus. So this is one case where a small capsular access was done, and to debulk the nucleus had a complication like this, turned into Argentinian flag sign. So there are still at this stage, there can be puncture access also, there can be laser opening in the capsule also in such cases. So ultimate goal is to have a safe nucleus management in such cases, and you have to save the capsular support at all cost so that there is a good prognosis in the terms of the vision. So in such cases, we have to discuss the outcome with the patient, and we should never overcommit. These days, laser flex has come also, and though it's a luxury, but in such cases, there is a precise capsulotomy, and lens fragmentation is good, and accurate incisions. But if at any time, in such cases, there's a difficult outcome, or if you're scared, or your heartbeat is getting fast, so you can have, if you know it, SICS is also always the option with us. In this case, I was doing, planning for phaco, done staining, and the lens was, swollen. There was much pressure inside. And ultimately, when I was doing, capsulotomy, again, it turned into Argentine flag sign. So I better thought that let me, change it to SICS. And such cases, after doing SICS, visual outcomes, after a few times of the follow-up, outcome is as good as the phaco. Nucleus is out, and we can have a good outcome in such cases. So in these cases, staining and visualization, they plays a great role with the trypan blue, and useful and safe, and gives a good outcome also. So this is another case where staining has been done, and we achieved a good capsular access. Ultimately, phaco was done successfully. So in these cases, intraventicular pressure and capsular access is the ultimate thing. If you manage this, thing is done. So for that, you have to use HVD also. Handling capsular fibrosis and jonular weakness is another thing. There if you are expert at dealing with microforceps or seizures, they come to a great rescue for you, and CTR rings are always there to help you. In these cases, I did a good capsular access, and ultimately did a direct chop. Again, after doing staining, in this case, release the pressure, but the Argentinian flag sign occurred, but the capsule was just short, so I used the micro seizures and did a good capsulotomy with the use of OVD and of course the micro forceps. And ultimately did the phaco. Another case, spiral capsulorhexis was done. Started from the smaller one and turned into larger capsulorhexis. That is another way to release the pressure. So there are intraoperative nuts and bolts that you have to use the active fluidics to maintain the chamber at all time, and there should be balanced aspiration flow and vacuum. So yes, flax has come. It is more expensive, and if the patient and surgeon both can afford, it is a good option for things. So summary in the clinical pulse are that you have to identify the jonular weakness. There should be good visualization with the help of the stain and of course the OVDs. If you can achieve CCC, that is good. Nucleus removal, novel choke technique or modern phaco-fluidics has to be used. IOL, of course, depending on the situation, you can use the IOL, and where you're fearing, you can use the technique of the SICs. Thank you very much. Thank you. Mike.
Dr. Krishnamurthy sir from Tirupati, please come on to the dais, sir.
It's a good presentation, and just a word. Sudhakar, just a word.
Oh, okay.
So many residents are sitting here in the audience. So just a word of, for example, there is a runaway rhexis. The flap is there, isn't it? So is it in the pre-equatorial region or to the extent post-equatorial? Is there any clinically, can you have a tip, like looking at the flap? There's something about you call them is the flap mobility sign, something like that, isn't it? You can look at the flap which is there in the, whether it is starting at the pre-equatorial or going on to the post-equatorial. Do you have any tips for the residents? Something like, they were.
Sir, if the flap, you have to identify that whether the, this flag sign is complete. So ultimately it has to be, change the technique, or you should not go with that typical phaco.
One important thing for residents is no rhexis, no phaco.
No complete rhexis, no phaco. Thank you, sir. Thank you very much.
So chairpersons also can join, sir. Dharmaraj, sir. Dr. Murali Krishna sir and Dr. Chalapati Reddy sir also please come on to the dais and occupy the chairs.